All right. Well, thank you so much for being with us today. Welcome to BEARCATS Health, Pediatric Obesity, and Respiratory Season Wellness, presented by the University of Cincinnati Alumni Association. I'm Bree Coggins, Director of Alumni Engagement for the College of Medicine, and it's great to have you all with us. I am co-hosting this session with my colleagues, Gage Woolley and Shelley Johnson, who support the other health colleges at UC, so College of Nursing, College of Valley Health Sciences, and the James L. Winkle College of Pharmacy. So thank you. The UC Alumni Association is here to support alumni success by positively impacting personal well-being and professional trajectory of our graduates. BEARCATS Health sessions provide health and wellness resources, unique opportunities to learn about critical healthcare topics and tools to improve quality of life for UC alumni and the BEARCAT community. Be on the lookout for more BEARCATS Health sessions coming up in the next few months. And a few housekeeping notes that hopefully we are all familiar with at this point, being virtual here for a few years. Please remain muted during the event to prevent feedback. If you have questions, please type them in the chat box, and we will be doing Q&A at the end. So we do want you to direct them to the chat box and write them down. We will monitor that, and then we'll do questions for both of our speakers toward the end of the hour. And as mentioned, this session will be recorded, and we will share it out with you who registered, and it'll be posted on our UC Alumni Association YouTube channel. So lots of ways to still consume this after this is done. So now to introduce our presenters, we have Dr. Nicole Baldwin and Dr. Christopher Bolling. So we will start today with Nicole Baldwin. She has been proudly serving her community as a general pediatrician at Northeast Cincinnati Pediatric Associates since 2006. After earning her medical degree from the UC College of Medicine in 2003, she completed her pediatric residency at Cincinnati Children's Hospital Medical Center, where she received the Outstanding Resident Award from the Division of General and Community Pediatricians. A passionate advocate for vaccines, Dr. Baldwin is also a pioneer in utilizing social media to educate parents and patients on pediatric health. Her impactful vaccine advocacy earned her the prestigious William H. Cotton Pediatrician Advocate Award from the Ohio AAP in 2020. Beyond the clinic, Dr. Baldwin shares evidence-based pediatric content with nearly 100,000 followers across Instagram, Facebook, TikTok, and YouTube, helping to spread crucial healthcare knowledge to families everywhere. And then I'll read Dr. Bolling's script or bio here first, and then we will have Nicole start her presentation. So Dr. Christopher Bolling is a volunteer professor of pediatrics at the UC College of Medicine, a graduate of the college and also the pediatric training program at Cincinnati Children's Hospital Medical Center. He co-founded Pediatric Associates in the northern Kentucky suburbs of Cincinnati in 1992. Over the ensuing 30 years, Pediatric Associates became one of the largest single specialty pediatric practices in the country. Dr. Bolling retired from Pediatric Associates in December 2022. Congrats, Chris. After residency and during a 3-year appointment in mid-career at Cincinnati Children's, he pursued research, advocacy, and clinical skills related to the prevention and management of pediatric obesity. He helped found the American Academy of Pediatrics section on obesity in 2009 and served in the section executive committee and chair through 2019. He has also published in the area of behavior change, obesity treatment, and community research. And most recently, he has been a co-author of the AAP policy statements on bariatric surgery and of the AAP clinical practice guideline on evaluation and treatment of overweight and obesity in children and adolescents of the AAP policy statement, the role of the pediatrician in healthy active living. He remains engaged in quality improvement, education, advocacy, and research activities. So thank you both to both of you for sharing your expertise with us today. And I will stop sharing now, so Dr. Baldwin can take it away.
Awesome, thank you. Let me share my screen real quickly and get into present mode here. All right, so can you guys hear me okay? All right, so thanks again for having me. I am here to talk with you guys today a little bit about respiratory season wellness, particularly when it in regard to pediatric care, because I'm a pediatrician, that's what I do. And in case anyone is interested, if you're on social media and you want to follow me, those are my handles for all the things that I do. I'd love to have more people seeing all the content, so you can check it out. Oh, here we go. Let's do this. All right, so today. Just a couple objectives. Number one, when we're finished with this brief discussion, I hope you're able to name 3 of the most common causes of respiratory illness in children, as well as I want you guys to be able to describe effective strategies to prevent respiratory infection, both in your kids and in yourself. So what are kind of the common causes of respiratory symptoms and infections in kids? So first and foremost, we think viruses. There's lots of viruses out there this time of year. Rhinovirus being very common, causes the common cold. We've got RSV, flu, COVID, parainfluenza, which can cause a croup illness, adenovirus, which also causes upper respiratory, eye goop, all that kind of fun stuff. We also have bacteria that can cause respiratory infections in kids. And fortunately, we have some vaccines to help prevent those bacteria, things like strep pneumonia, H. flu, mycoplasma, and pertussis, which unfortunately we are seeing a little bit of an uptick lately in pertussis. So that's an important one to note. And then in our environment, while we're not necessarily causing an infection per se, certainly respiratory symptoms that can mimic infections, things like allergens, dust mites, pollen, animal danders, irritants like smoke, pollution. When we had all that wildfire pollution recently, or I guess that was a while ago, but we had a lot of asthmatics coming in with respiratory symptoms from that. And then just the cold weather, kids being out in the cold can trigger asthma and other respiratory symptoms. So thinking about the scope of disease, children are generally going to develop about 6 upper respiratory infections on average every single year, and these infections can last 7 to 14 days. So if you think about these infections that are coming between usually September and March or April, and they're lasting 2 weeks and you're getting 6 of them, it can absolutely feel like kids are sick all the time. And we see that a lot. Parents come in and they're worried that there's something wrong with their immune system, and that's not necessarily the case. It's just kids get a lot of respiratory infections. 3 in particular that I want to talk about that affect a lot of us in pediatrics. RSV, we've been hearing a lot more about RSV lately. Pediatricians, it is the bane of our existence. One of the reasons is that it is the most common cause of hospitalizations in kids under the age of 1, causes over 2 million outpatient visits every year and up to 80,000 hospitalizations in kids under the age of 5. And until last year, we didn't have a whole lot we could do for RSV other than supportive care. So I'm going to talk in a minute about what we can do to help now prevent RSV infections in kids. Influenza, obviously, I think we're all very familiar with influenza. Another reason that we have high hospitalizations in kids under the age of 5, and infection rates are really high in kids with influenza. Unfortunately, this past season, the 23-24 flu season, we saw the highest number of pediatric deaths since the 1920 season. We just had our 200th pediatric death in the beginning of September, unfortunately. So that's why it's really important that people are getting vaccinated to help prevent influenza. And then lastly, COVID-19, I feel like we're still learning more and more about COVID, but we've got a little bit under our belt. So generally it's a mild infection in most kids. However, kids with certain underlying health conditions and children under the age of 6 months can still have complications, be hospitalized, not to mention things like long COVID. So it's still an important cause of respiratory infection that we need to pay attention to in our kids. So fortunately, there's a vaccine for a lot of these things. And I think you heard in my bio, I'm a very passionate vaccine advocate. And I think it's really important that we understand that the only way to boost our immune system is through vaccination. A lot of times I have parents come in asking for ways that they can boost their kids' immune system. And this is how you do it, right? You get vaccines. So certainly we have scheduled childhood vaccines that we give routinely starting around age 2 months that can help prevent things like pertussis and pneumococcus and Hib. Those can cause things like pneumonias and ear infections. So we definitely want to make sure our kids are staying up to date on their scheduled childhood vaccines. And then we're going to talk a little bit more detail about flu vaccine, COVID vaccine, and a new RSV immunization option that we have for our youngest kiddos. So flu vaccine, again, it's recommended for everyone 6 months of age and over each season, not just one and done, right? Every season we need updated flu vaccines. Children who are under the age of 8 who've never had a flu vaccine do need to get 2 vaccines in a season, about 4 weeks apart, to ensure that their immunity is up to snuff for that season. Typically, we recommend that these flu vaccines are given prior to October 31st, or as we pediatricians like to say, flu before boo. Get those flu vaccines prior to trick or treat so that we know our kids are protected at the beginning of flu season, which typically the height is usually sometime around December to February, depends on the year. Flu vaccines also recommended in any trimester of pregnancy, both to protect pregnant moms who are at higher risk of complications from influenza, but also to help protect that infant. So moms will make antibodies that then pass across the placenta, and they can then help protect that infant from birth until they're able to get vaccinated at 6 months of age. This year, the flu vaccine is a trivalent vaccine. So in the past about 10 years, it's been quadrivalent, meaning it contained 4 strains of the virus. But for the past this year, it's only containing 3 strains, 2 A strains and 1 B strain. The other B strain, the B Yamagata lineage strain, hasn't been present in the U.S. since 2020. And so they decided not to put it in the vaccine this year. COVID vaccine recommendations. So the new updated 2024-25 COVID vaccine is recommended for everyone 6 months of age and older. This slide is kind of busy, and it is busy in our brain as pediatricians because there's a lot of kind of nuance to who gets what. So essentially there's 2 big broad categories. I think we all know this of COVID vaccines. You have your mRNA vaccines and then your protein subunit vaccine. When we're looking at mRNA vaccines, they split it out between kids under the age of 5 and kids over the age of 5. So for my littlest kids, it depends on what manufacturer they're getting. So if they're getting the Moderna COVID vaccine, which is a 2-dose series, they need 2 doses if they've never had any. And if they've had one, they only need 1 dose. All right. But if they're getting Pfizer, then unfortunately that's a 3-dose series. So it gets a little more complicated. If they've had no doses, they need 3. If they've had 1 dose, they need 2. And if they've had 2 doses, they get 1. So again, a little confusing, but pediatricians, we've got it. We know, just be sure to check with your pediatrician about what your child needs. And then finally, in the mRNA vaccines, if kids are over the age of 5, regardless of whether or not they've had a COVID vaccine, they only need 1, whether it's Moderna or Pfizer. So that makes it a little bit easier. And then for our kids 12 and over, they are also eligible to receive the Novavax vaccine, which again is a protein subunit vaccine. If they've ever received any COVID vaccine, they only need 1 dose of the Novavax. But for kids who have never received, or adults who have never received any COVID vaccines, then they need 2 doses of the Novavax. And one of the reasons that some people are choosing Novavax over the mRNA vaccines is just a side effect profile. Novavax tends to have fewer of like fevers and just malaise and sore arm side effects that the mRNA vaccines do have. So again, it's another option for our families who are a little leery of the mRNA vaccines, although they're very safe. There is something for them for if their kids are 12 and over. And then finally, this is the most exciting thing for pediatricians. As of last year, we actually have both a vaccine option and an immunization, and I'll explain that in a minute, for protecting our youngest kids from RSV. So there is a vaccine called Abrysvo. It is manufactured by Pfizer that is given to pregnant women between 32 and 36 weeks of gestation. And this allows them to produce the antibodies that they then pass through the placenta to the infant. This vaccine is given between September and January to help protect those infants that are born during RSV season. And those antibodies that baby gets are present for about the first 6 months of life, as long as mom got the vaccine at least 14 days before she delivered. So for the infants who are born to moms who did not get the vaccine, or if they got the vaccine and then delivered within that 14-day time period, there is a monoclonal antibody that is an option. It's called nirsevimab, or the brand name is Beyfortus, and it is a passive immunization. So I think what's important for people to realize is it's not a vaccine. So a vaccine is something we get that induces antibodies in our own body to protect us from an illness. But this monoclonal antibody is human antibodies that have been purified and amplified, and then it's just given in an injection. So immunity is immediate for these infants. It can be given at birth up to age 8 months during their first RSV season, and the immunity lasts about 5 months for these little ones. We do dose it based on their weight. And some children with high risk conditions can get a second dose, their second RSV season, if they're between the age of 8 months and 19 months. So this, we just came out last year. There were some supply issues. So we had a little bit of struggle trying to get it out to the broad population. This year seems to be going much better. We started immunizing as of last week, October 1st. And the plan is that through March, these kids will have the opportunity to get protected. And we're really hoping to be able to decrease the rates of hospitalizations in our little kids. Just want to touch on Synagis or palivizumab, which is a monoclonal antibody very similar to Beyfortus. The only difference is that the Synagis only lasts a month, the antibodies do. So the children have to get that injection monthly. That was licensed back in 1998, but only reserved for our very premature infants, less than 29 weeks gestation, chronic lung disease of prematurity, or kids who had hemodynamically significant heart disease. Now, Synagis is still available, but actually it's recommended that even those young kids can get Beyfortus since it lasts a little bit longer. But if there are supply issues, or if parents decline the nirsevimab or Beyfortus, then those infants that qualify will still have the palivizumab or Synagis available. So beyond vaccination, what else can we do to stay healthy and to keep our kids healthy this respiratory season? First and foremost is sleep. And this is a big one. And it's really especially important for our adolescents who are just not getting enough sleep. So trying to make sure that your kids and your adolescents and you are getting at least 8 or more hours of sleep every night to help keep your body healthy. Obviously with hand washing, we all know how important that is, and teaching our really young kids, especially because they like to touch everything and then touch their face. And so working on teaching them how to appropriately wash their hands for the right duration of time. Getting outside and playing, being physically active, that can help support a healthy immune system. Diet is so important so that kids are getting a variety of vitamins and minerals. And I'm going to talk in the next slide about certain vitamins and minerals that can help support our immune system. Again, not boost, but support a healthy immune system. So that's very important. And then respiratory hygiene. So teaching our kids the right way to cough into their elbow or sneeze into their elbow, or wearing masks when they're sick. That can help keep other people around them healthy. So supplements is a touchy subject, and I actually don't typically recommend vitamins or supplements unless parents are really pushing me on it, but I wanted to address it because I think we get a lot of questions about it. And if anyone is interested in a deeper dive, the link I have on here is a great fact sheet for all things supplement and all the different research that does or does not exist for these things. So you can see there's a lot of vitamins and minerals that are listed here. Those are vitamins and minerals that are shown to help support a healthy immune system. But again, we get most of those through our diet if we're eating a varied diet. So the ones I want to address for you guys briefly, that there is maybe some evidence. Again, the evidence is all kind of up and down, but something like vitamin C, there is some evidence that if taken prior to developing a cold, it might help decrease the duration of a cold. So again, maybe could help, but once we're already sick, it's not necessarily going to do a whole lot of good for us. So you don't need to be pounding the emergency if you're already sick. Zinc is one that has been shown if it's taken after someone has a cold, it might decrease the duration a little bit. Now that's if you can get your kids to take it. Zinc does come in the form of some lozenges or syrups, but it tastes a little metallic-y. I remember when my son was little and I tried to get him to do these zinc lozenges when he had a cold, and he wanted nothing to do with it. But again, something to try. From a standpoint of botanical supplements, I, again, don't typically recommend these, but I have parents coming in and asking me about them. Specifically, echinacea and elderberry have been studied in kids, so at least I have some evidence in them. And echinacea might reduce catching a cold a little bit. So if parents are really wanting to do something to try to help with that, and then elderberry might help reduce the duration of a cold or severity after it's already started. So again, if parents are really wanting to give these, just make sure, especially a lot of these come in gummy forms. So we want to make sure that if they're giving gummy supplements to their kids, they're brushing their teeth afterwards. They're making sure that they're from reputable companies and making sure they understand that these are not regulated by the FDA. And so we just don't always know what's in them, which again, another reason I don't tend to recommend those supplements. And then from the other category, omega-3s and probiotics, omega-3s have been studied as additions to infant formulas. A lot of the infant formulas that we give contain omega-3s. And when they studied and looked at those infants who took formula with omega-3 versus took formula without omega-3, those kids who took the formula with omega-3 did have decrease in incidence of respiratory infections. However, one thing to note, this was not compared to kids who were breastfeeding versus formula feeding. And this is not a reason to encourage someone who is breastfeeding to take formula. So just note that. But if parents are asking about the formulas that are supplemented with omega-3s, it might help some. And then finally, probiotics. Again, there are lots of studies, but nothing super conclusive. And the challenge is that the strain of the probiotic is really geared towards specific illnesses. And a lot of what is marketed towards kids, especially the L-reuteri and Saccharomyces, are more for diarrheal illnesses versus respiratory illnesses. There is some data about a different, I actually had to write this down so I would remember, Lactobacillus acidophilus and Bifidobacterium animalis that can help with respiratory infections potentially. But those aren't necessarily always the strains that are in probiotic supplements for kids. So just know that for parents, if they really want to feel like they're doing something, I don't think there's harm in it. But again, we have to make sure they understand they've got to make sure they're getting the strain that's actually going to help the illness that they're trying to prevent. So with that, quick take home points. Number one, obviously kids are getting sick. There's lots of things causing respiratory infections like viruses, bacteria, and different environmental pollutants. However, our best and most efficient way to boost our immune system is through vaccination. And number three, just remember making sure we're getting a healthy diet, eating fruits and veggies, running around, playing, getting our good sleep, all of that. So with that, quick little primer on respiratory season, I want to say thank you. And just a shout out to my own BEARCATS. My son is a 2019 graduate of the Lindner College of Business, and my daughter is currently studying pre-physical therapy, and she will be UC class of 2026. So go BEARCATS.
Awesome. Thank you so much, Nicole. Very exciting about the RSV options. That was one main reason why I wanted to do this topic. I knew that was a new opportunity to talk about. So thank you for all of that.
Yeah, absolutely.
All right, we'll go right into Dr. Bolling.
Hi, thanks a lot, Nicole. Thanks, Nicole. That was Bree. Thanks, Bree, and thanks a lot, Nicole. That was actually really a good summary of things. So I'm going to be talking a little bit today about where we are with pediatric obesity. I mean, this has been a topic that's been, kind of in and out of a lot of discussions over the several years. So I wanted to give everybody just sort of a big view of where we are with pediatric obesity. And there's also been some really interesting developments more recently on it. So when we talk about pediatric obesity, first off, I want to tell you who I am. As Bree said, I'm a retired pediatrician from Northern Kentucky, UC class in 1987, and I'm a generalist like Nicole. We generalists get involved in a lot of specialized areas, but we're still primary pediatricians at heart. And we really try to keep the whole child in mind. I'm a former chair in the section on obesity, which has been a really interesting role to have. And I'm really interested in obesity and obesity prevention across the entire age span, all the way from infant feeding. And I'm one of those weirdos that really likes dealing with adolescents too. They're a lot of fun. I'm also kind of a geek for community research and behavior change stuff. So you'll hear a little bit about those things as well. But I've always been involved with UC's Center for Clinical and Translational Research because I love the community-based stuff. I have nothing to disclose as well. My objectives are pretty basic. I want you to be able to, we're going to describe the key aspects of effective obesity management, and then also list the 5 domains that are associated with kind of with obesity prevention or the promotion of healthy, active living in children and adolescents. And I'd also say families. So these are sort of the more recent, but this is a very kind of famous slide set that comes from the CDC. They update it every year. And we've been watching this slide set since the early 90s. I'm not starting all the way back at the 90s, but I want to give you a little bit of context over these next 10 slides that we're going to go through really fast. So if you think about it and you're kind of a data geek, you're thinking like, okay, what is this rate of, we talk about obesity was sort of defined as being greater than the 95th percentile for your BMI. Well, like that should be 5% of the population, right? If it's 95%. Well, things have really changed. It used to be that was 5% of the population that had a BMI greater than 30, or when you're a kid, 95th percentile for BMI for age and gender. Well, we've really kind of fallen off that. That's really gone a lot more. We're way above that at this point. So the average numbers and the percentiles are really not 5% anymore, and nowhere close. And you're going to see that from this data. In fact, they're so far different. You can see that every state in the union as of 2011 had 20% or greater of patients, adults who had obesity. So, typically it had been 5% up into the mid 80s. And now in 2011, you can see that it's greater than the states with the lowest rates still have 1 in 5 to 1 in 4 adults having obesity. And the states that had higher ones, states like Kentucky and Indiana and Ohio, were in the 30 to 35% range. Well, that was 2011. So 2012, we see a little bit more of a march. We see a couple states, West Virginia and Mississippi. And as you know, I think Bree said that I'm a native Kentuckian, and the state motto there is "Thank God for West Virginia." And then we see Arkansas coming across the line, and more states crossing into that 40 to 45% of their population having obesity. And so we see a large swath of states going into that third of the population. We see Mississippi first cross that 40% line in 2019. They kind of go back, but then Kentucky and West Virginia go over the 40% line. And then we go to 2022, the effects of the pandemic. And we see a lot of states crossing that 40 to 40% line. And then we see some states crossing the 45 to 50% line, which is just shocking. We're missing some data here in Kentucky and Pennsylvania. I don't want to give you the impression that they suddenly started doing better. They just didn't have enough data to report. But you can see where we've just really like fallen off the deep end in a lot of states, and we're approaching 50% rates of prevalence of obesity in certain states, which is just staggering. So what are the factors that are associated with overweight and obesity? You think about the states that you just saw, there are a lot of things that correlate with that. We could put on things about socioeconomic status, oral health, type 2 diabetes rates, heart disease, vascular disease, all sorts of things correlate very closely in these places because overweight and obesity, like these other illnesses, are associated with race and ethnicity and socioeconomic status and social determinants of health. So these things all have a positive, there are definitely relationships, and increasing adverse childhood experiences worsening socioeconomic status probably has the most profound impact on obesity rates. Where we are now currently with kids, we estimate that 14.1 million children and adolescents in the United States are affected by obesity, probably double that amount if you include overweight. It closely mirrors the rates in adults. It increases from year to year, meaning that this year's 5-year-olds have a higher rate of obesity than last year's 5-year-olds, and it increases with age. So we have higher and higher prevalence rates of obesity as we move forward. So with all that happy, cheery news about the increasing rates of pediatric obesity, what are we to do about this? Well, we actually have a thing called the Obesity CPG, or the Obesity Clinical Practice Guidelines, that was put out by the American Academy of Pediatrics about 20 months ago. So we've had 20 months of experience dealing with this thing. And the reason we put it out is because there's data to support what we can do to help evaluate and treat obesity. What we did was had the really good fortune, and it was really fun to be on this writing group with about 25, 30 other pediatricians and public health experts from around the country with the help of the American Academy of Pediatrics. It had been 15 years since we had just even expert guidance. This is the first time we did what's called a clinical practice guideline, which has to have a lot of hard data behind it. Not all the data is equal, but we could actually make some statements based on what data now exists after 15 years after our last sort of just expert, hey, here's what we think is a good idea. So we looked at 16,000 abstracts. We took 1,600 full text articles from those 16,000 abstracts, and then boiled them down to about 300 300 to 400 studies that developed 2 technical reports, 11 consensus recommendations, and 13 key action statements. So what does that mean? Okay, so the technical report is just this compendium, this whole variety of data in big long form where we conjecture about everything, how all academics, how we like to do that. And then we came up with 11 consensus recommendations, which are things you can't really test for with evidence. Like things like, and you'll see what I mean by some of these. They're things like you should take a good history and physical and look at social determinants of health. You can't really do a double-blinded study where you don't do those things. So there are some recommendations that came out of this group, but then these 13 key action statements have varying levels of data behind them, but they're really hard data-driven statements that we can say, this is what you should be doing, this is what you can consider, these are things you can offer to families that we know are rooted in evidence. It's not just my opinion. If you can tell, we're really getting away from that zone of eat less, exercise more. We actually do a lot more than that now. So the document, the clinical practice guideline, is really broken into 2 sections. There's an assessment and evaluation section, and then there's a treatment section. So let's talk about the assessment and evaluation that we now recommend for kids with obesity. First off, we should still use BMI. We knew this thing was going to be controversial when it came out 20 months ago, and we thought, well, we're just going to lead with controversy. So we all know that BMI is a flawed measurement, but it's what we've got. BMI was designed as a population-based measurement. It really wasn't designed to be used on individual bases. However, having said that, it still works reasonably well if you treat it as a vital sign. If someone comes into your office and they have a heart rate of 50, do they have heart block and are they sick, or are they a highly trained athlete who has a heart rate of 50? So we do this with other vital signs. And what this clinical practice guideline says is we should do the same thing with BMI. It can give us a clue. It can tell us, hey, this is in this range, this height for weight is in this range. We need to look at it more. We need to think, what does this mean for this patient? Not necessarily that means if you have this BMI, you do this and you start this medication, but it starts the conversation. It's a vital sign. The consensus recommendation also says we should also be doing this in a longitudinal and individual way. We need to be looking at BMI. We need to be looking at BMI curves. What's happening over time? Is this a recent occurrence? Is this a lifetime of issues? And what's happening in the individual basis with regard to this to the structural things around our patients. Like, what's their environment like? What are their genetics like? What are all these things that are influencing their weight status and their health status? The second key action statement says that we should also not pay a blind eye to all these other things. I always make the comment, for those of us who are in the obesity world, we are chaos lovers. Like, there are certain people, who like to who bring order out of chaos. That's obesity specialists. We like that. Not everybody does. But what I will say is that, obesity is complicated. There's so much going on. It's genetics, it's environment, it's cardiology, it's endocrinology, it's genetics, it's all these other things going on. And so you really need to have sort of a global look. How is this patient's weight status affecting them? It's all about health. This is why we're concerned about it. We're not concerned about we are concerned about it, but about our appearances. But what we really are doing this for is about health. And really, mental health has a big piece of this as well. What we do know also, we can talk about healthy at any weight, we can talk about these things, but what we do know is that obesity affects the immediate and the long-term health of children. Children with overweight and obesity are susceptible to many diseases like type 2 diabetes, high blood pressure, sleep apnea, liver disease, and depression. It affects all sorts of parts of our body. It can also affect some of those areas you wouldn't think of necessarily. Things like polycystic ovarian syndrome, which can affect fertility. It can affect orthopedic issues, a thing called SCFE, or slipped capital femoral epiphysis, or Blount's disease, where there's actually bowing of the tibias. So there's a lot of things that can really be affected by excess weight. And it's up to us to really evaluate those. And that's what this clinical practice guideline talks about. It also made a strong statement, and I'm not going to get into the weeds about how you should screen, and we just did that with the family medicine department this morning on this topic. But what it does say in one of the key action statements is we need to treat these things concurrently. It doesn't make sense to treat hypertension and treat obstructive sleep apnea and maybe or maybe not treat the obesity. We need to do it all together. They're all interrelated. They all affect each other. It's a big combined mess, group, whatever you want to call it, but everything is affecting everything else. And we need to have a comprehensive view when we're trying to treat obesity and we're trying to treat the comorbidities that go along with it. So what does treatment look like these days for kids? It's really, I think it's adult medicine plus a lot other support. So one of the hallmarks of this document is to say that we should treat overweight like a chronic disease, like we treat asthma, like we treat diabetes, that there are behavioral things that make a difference, but we also need to use all these other tools at our disposal that we use for around these other chronic diseases, meaning we need to use a chronic care model. We need to emphasize the medical home where you get your treatment at your primary care doctor. It should be family-centered because these are things that affect an entire family, healthy eating, healthy living. And it should be done in a non-stigmatizing, non-weight biased way. So what do I mean by that last piece, weight bias and weight stigma? Well, we have ways of kind of going into offices and have offices look at their own offices and say, like, what kinds of things are we doing in our office that might give implicit signals to our patients that their weight and their weight is somehow their fault. Things like using candy as a reward, promotion of screen time, not having furniture that fits different size bodies. Those are things that really, if you're someone who's a larger person, those are things that really affect you. I'm like, this place isn't really equipped for me. And we also encourage them to not be so focused on weight, but to be focused on health and making sure that weight is done sort of in a private sort of area for families. I think really when we're trying to avoid weight bias, I don't know if you know, can see this picture is from the Rudd Center at the University of Connecticut. And rather than showing people with larger bodies laying on a couch or eating fast food or all these things that promote weight bias and weight stigma, they have people being healthy and they have people going about their active daily lives. What we can do as providers and what the clinical practice guideline encourages us to do is recognize the complexity of obesity, acknowledge the effort that our patients have already made, let them explore some of the negative experiences, and really focus on outcomes other than just weight. This is about health. So if we have a patient who improves their health, their weight doesn't change, but their health improves, mission accomplished. This is a diagram just to think how we talk with practices about their medical home and how we can kind of ratchet up therapy inside the pediatric office or family medicine office to kind of treat obesity as a chronic disease. There's another thing I think I said, too, that I'm a geek about behavior change. I'm a big believer in motivational interviewing, and motivational interviewing is a behavior change strategy where you really acknowledge the patient's own desire to change and their motivation to change. So it was one of the things that we did from this guideline was really encouraging pediatricians and pediatric healthcare providers to get better at behavior change counseling. We give them resources, and these are really kind of fun resources to learn these techniques where you don't get so frustrated and you get out of the blame game, honestly. We also teach them how to do IHBLT, or better known as intensive health and behavior lifestyle treatment. That mouthful, or IHBLT, is something that in an ideal world is very, very intensive. But our message to pediatric healthcare providers is you do what you can do, that some is better than none, more is better than some, and a lot is great if you can do it. But the evidence is pretty strong that even if you can do just a little bit, that helps certain families. When it's not available, we really encourage them to partner with communities, things like food pantries, extension services, YMCAs, Parks and Rec. There are a lot of really interesting partnerships that are coming out around pediatric obesity. Key Action Statement 12 said that pediatricians and pediatric healthcare providers should offer adolescents with obesity pharmacotherapy. This was probably the most controversial statement that came out, but it should be an adjunct to health and behavior lifestyle treatment. We don't expect all primary care providers to be able to be writing for Mounjaro or Ozempic, but they need to have an understanding of what these medications are. And those who are motivated, we want to be able to support them. And actually, the data suggests, we couldn't make a key action statement around it, but the data suggests that even sometimes as young as 8 to 11 for kids with severe obesity who are experiencing side effects. That's really young. I mean, it's really young. Similar statements were made around metabolic and bariatric surgery that, 13 and over, we need to really be talking with our families about this and saying like, we're in a zone where this is what the obesity is causing. We need to be honest with their families. And there's actually a lot more data around metabolic and bariatric surgery in adolescents than there is even about pharmacotherapy. I think everybody thinks, oh, pharmacotherapy is much less invasive. Well, maybe, but it's a lot less, there's a lot less data on pharmacotherapy than there is around metabolic and bariatric surgery. And what we really try to do with offices, and we try to have them go where they're comfortable and not just general, we're talking about everybody. Everybody needs to figure out where they're comfortable with this. And if a provider is comfortable just doing screening for other illnesses, that's great. That's a step forward. You can't address a problem if you don't know that you have the problem in the first place. For some of those practices, it means going all the way over to starting a health and behavior lifestyle treatment program in their office. For some places, it means just being a good referral base. So we really are, like we do with our families, we really do this with providers too. It's like you need to decide where this fits in your hierarchy on what you can address. There's also a lot of advocacy opportunities for improving funding, both for intensive and health behavior lifestyle treatment and for pharmacotherapy and for surgery. Okay, so what about prevention? I've talked about these kids who have obesity. What about kids who were trying to prevent obesity in the first place, which is really, really important. And as a pediatrician, the thing that's probably nearest and dearest to my heart is we should be really working upstream on this. We need more data, honestly. We're beginning to learn. And what we're learning is, I think we're learning some ideas about where the obesity epidemic really came from. You know, everybody, I always talk about these cocktail party conversations. When somebody finds out that I work in pediatric obesity, you'll get the comments like, well, I think it's sweet drinks. Well, I think it's lack of activity in the community. I think our communities are not walkable. Well, I think it's because they got rid of PE at school. And have you seen how bad school lunches are? And my response to those questions is, yes, you're right. It's all of those things. So what we think happened is it's been sort of this convergence of things that we all have always had this genetic predisposition, but we happen to bombard ourselves with a lot of environmental triggers all at the same time. All of these things probably contributed to making us sort of activate these genes that we have that evolutionarily have been there to kind of get us through starvation periods. So, you know, what these factors are can be all sorts of things. This is the old socio-ecological model where we talk about, you know, the central point being the child's weight status. And then there are these child characteristics, the family genetics, their behavior patterns, their dietary intake. But then on the outside of that, there are family things, sibling interactions, parent activity, parent food preferences, what food is available, foods available in the house because of economic reasons. And then there are the community and social demographic factors that factor into these things that can also be triggers. Availability of recreation, school schedule, work hours, PE programs, crime rates in your neighborhood. All these things have a really profound impact. I remember doing a talk from a grandmother who was the primary caregiver in Avondale. And I said, you know, we need to get outside and do more activity, blah, blah, blah. And this grandmother, who's a primary caretaker, just said, Dr. Bolling, like, kind of like, what are you smoking? I mean, like, you know, this is, I'm worried about my child getting shot when they walk out the door. And I'm going like, yeah, that's probably more important than what I'm telling you. So all of these things factor in for our families. Well, what we know so much about well-being and wellness in adults really does still affect kids. It's the same stuff. And the policy statement, we just came out with a clinical report actually on healthy active living. We really talk about 5 domains. We talk about nutrition, activity, sleep, as Nicole also talked about with infectious diseases, social connectedness, and media use. And under social connectedness, I'd also say emotional, mental well-being. And this extraordinarily busy slide is one of the charts that we have in our Healthy Active Living manuscript that we just came out with, and really talks about how you take a developmental approach. So on the left side of this chart, you see infancy, toddlerhood, preschool, school age, and then these 5 domains that I just mentioned: social, emotional wellness, media, sleep, activity, nutrition. And I would kind of make a case that roughly that's sort of the order across the top that are most important, although they're all 5 very important. And this just gives pediatricians and pediatric healthcare providers ideas of things that they might address with families when they're trying to do some good obesity prevention. I would say stay tuned to obesity prevention. We got a lot more hopefully coming out of that in the near future. You know, so the key takeaways from all of this is that we now think of obesity not as like, oh, what is happening kind of thing. It's a chronic disease and it's complex, and we need to embrace that. We need to treat the whole child, and I would say the whole family. Obesity treatment is now safe and effective. There are effective evidence-based treatments that can be tailored for individuals. And it also means treating comorbidities. We shouldn't just be watching and waiting, as we used to say. We should be offering treatment early with effective evidence-based treatments. So with that, I will turn it back over to Bree and see if we can answer any questions for you.
Perfect. Thank you so much. No, a lot of the framework pieces in there will be really helpful to have in the slides afterwards. So thank you for pulling all that together for us. So we don't have any questions in the chat currently. And at this point, if you want to type it in the chat, we could have an open discussion. If you feel more comfortable going off of mute, that's also okay. but we have about 9 minutes till the top of the hour available. If anybody has any questions or comments. I have a couple in my mind, but I'll wait. Yeah, and if either of you, now we have a few seconds left if we wanted to add anything else that you didn't get to cover.
I'd love to hear your questions, Bree.
I think one of mine was for Nicole. In the last few years, especially with the pandemic, there have been sort of seemingly kind of exponentially higher waves of certain illnesses, for all these environmental or, societal reasons. I guess just kind of generally understanding that, how that happens, what contributes to that, if there are any kind of on the radar for this upcoming season that seem to be, more problematic or that doctors are nervous about. So yeah, just I think more generally as a non-clinician, just curious how that works and what you look out for.
I don't know that we totally know. I think one of the theories, at least working theory in my mind and a lot of my colleagues, is that, when COVID kind of started and we locked down, what was very interesting, we were in the middle of a huge wave of flu and this virus, we had no idea what it was, which turns out it was COVID. And then, we shut down and it respiratory infections went from here to here in a week. Chris, you were still practicing, right? So you remember this? And even what was so interesting about it was even in the kids who were in daycare and stayed in daycare, and these infants were there, they did not get sick. I did not write a prescription for an ear infection for almost a year. And I think a lot of it was how much these kids that were in school and parents in the workplace actually are bringing these infections home to their kids. So we went through a year where we didn't have a lot. We also had a lot of people having babies. And then, slowly as we opened back up, I think what happened is those kids that were born during the pandemic that weren't exposed to a lot of germs for a year or two, and then some of these parents were coming in and having a second child, then all of a sudden we open up and it's just boom. I feel was it maybe 2022, 2023? It seemed like everything hit. We had RSV in the summertime. I had kids hospitalized in June with RSV. We were like, what is happening? And I think it just we got off cycle because our behaviors had shifted so much. It feels now like we're getting back to the way it used to be, right? I feel like we're kind of back in that seasonal pattern. We're still trying to figure out the COVID pattern. It definitely seems like we're getting more COVID infections kind of summertime-ish sometime. But for now, I don't feel like there's anything that's different than pre-pandemic necessarily. There's nothing that I can think of other than pertussis right now is kind of rearing its ugly head, especially on college campuses and things like that. But yeah, I kind of think that's why we had that weird.
That summer of 22 was so weird.
Yeah.
It was so.
Perfect. Thank you. Yeah, Gage, if you wanted to take the few in the chat.
Yep, absolutely. So we have a couple questions on the chat. One's from Nan. Are you seeing much long COVID in children and adolescents? If so, what effects are you seeing?
I would admit we're not seeing a ton. And the challenge is that adolescents are tired. Adolescents are fatigued. Adolescents have, again, we talked about how many respiratory infections kids get. And so it's hard to know, is it truly long COVID or not? But I don't think we're seeing a ton of that, which is great. But, it can still happen.
And this is a follow-up question to that. Are parents getting their children vaccinated at good rates for COVID?
No, they're not. Rates for COVID vaccination in kids are pretty abysmal. We always have, and unfortunately, even our flu vaccine rates seem to be decreasing a little bit. I think, unfortunately, there was a lot of distrust in vaccinations since COVID. And so that's something that we as pediatricians are really paying attention to, and we're very concerned about, because it's not just COVID and flu that's dropping. It's other things too. So yeah.
Those are the only two questions in there. However, if there's other folks, we'd love to hear.
I have a question for Chris. I'm curious, I've seen some stuff in media about like the microbiome and its effect with obesity. Is there much research about that or research in kids or anything?
Yes, there's a lot. There's a lot. We didn't drill, you can't drill into a whole bunch of things here, but yeah, there's a whole bunch going on with that right now. And I think, there's a lot of questioning about like, what is we didn't go at all into like what are the appropriate nutrition plans to try to pursue. And a lot of the nutrition plans actually, really try to pay attention to the microbiome. Um, but no, I think it's really important that we're doing that. And I don't think so. There's a lot of ongoing studies. I'm trying to think of some of the more interesting ones out there. I know some of my colleagues have some really interesting ones that I'm just kind of blanking on right now. But yeah, no, the microbiome is definitely a big topic area.
Yeah, I mean, I saw something about like fecal transplants for like, again, this was on some crazy Netflix documentary, but this one was like
Yeah.
doing a fecal transplant from someone who was overweight and then she started to gain weight and then went back. And I'm like, is that true? Is that not? I don't know.
I think it's really important, but I also think we're at that zone where we just don't have enough data yet.
Yeah.
Like I think we like to think like, oh, take this probiotic and you'll be great. And I'm like, it's going to be more complicated than that.
Yeah. Yeah.
Yeah, I just feel like we're really, really early in understanding the microbiome.
Yeah.
Another follow-up question from Nan. What community programs are available for childhood obesity, or are most pediatric practices providing their own?
So they are not. So this is a great question from Nan because we're seeing that these programs actually are helpful and that they work, but they're just not there yet. So there's a lot of study when I talk with practices, we give them a list of some sort of canned programs that are out there. Like the CDC has some, the American Academy of Pediatrics has some that they sort of I wouldn't say certify is too strong of a term, but ones that are evidence-based. In Greater Cincinnati, some of the ones that are there, I mean, sort of the gold standard one is the one it's the children's called HealthWorks, which is a multidisciplinary program that has cardiology, endocrinology, gastroenterology. They have an exercise program. They have really skilled dietitians. And Nicole and I both know it's really hard to get into. So it takes a while to get into it, but the key with these programs is making them available for when families are ready to do it. A lot of this is about readiness to make changes, and sometimes families that's just not on their in their ability quite yet, so they have to be ready when they're there. So some of the more interesting ones that are out there, I think you're going to see more occur. The Y has been dabbling in this for a long time, so I expect the Y to kind of come back into it. I kind of expect there's a really interesting program coming out of North Carolina right now called Fit Together, which is run through Parks and Rec. So I'd love to see our Hamilton County Parks, Cincinnati Park District. We'll see what happens, but I think we're going to see more and more things come online. You're going to see some practices do like our practice did, where we have sort of like a lighter version of an IHBLT in the program. So I think you're going to see more come online. We kind of hope that this clinical practice guideline is a bit of a clarion call. They're like, okay, now it's time. There are programs, start putting them out there.
Yeah, we actually have an obesity medicine physician certified now at our practice, but I think besides when you did it, Chris, at yours, I don't know that any other practices have that. So it's very specialized.
Yep. Yep.
Great. Well, we're at the hour, so we will go ahead and close our session for today. But thank you again, Dr. Baldwin and Dr. Bolling, for your expertise and for the discussion. We really appreciate your time to come and share this with our fellow alumni. Just wanted to put a plug for UC Homecoming next weekend. So it's the weekend of October 18th and 19th. It's a noon football game, 8 a.m. parade on Saturday. So we really hope to see you all there. And at any future BEARCATS Health sessions. We really appreciate your participation and engagement and look forward to seeing you all soon. So thanks and have a great afternoon.
Bye-bye.
Bye. Thank you.